So what is the implication?
So we have to attend early.
Exactly. As simple as that. More and more, we used to say pain is protective. This is what we learned, I'm sure, in our early physiology. Pain is protective. So it is helpful for body to localize the cause of problem. So especially when olden days, when you used to have appendicitis, they used to say, don't take away the pain because it will help us to know whether whether disease appendicitis is progressing to any complication. So we used to not treat pain and just leave it like that. But now the trend is changed. They say we have better ways to diagnose the underlying cause of pain, but pain should be treated early. If you leave it untreated for longer period of time, it can lead to problem. So this is the more and more people talking about early management of pain. So what they say is that earlier the pain is treated, the less these self-perpetuating changes. That's the first thing. Second is, when they have continuous pain, you can't give them some pain relief for a period of time and let them have pain later on. Again, that can also trigger these changes. So they say all pain warrant continuous analgesia. So when they have pain, you continuous, so chronic pain means continuous pain. So you have to give continuous analgesia. You can't be giving them intermittent analgesia. And once, suppose total relief is difficult, if once the permanent changes takes place. So these are the clinical relevance which we see in chronic pain. Are you with me on this?
Yes. Yes.
Yeah, please. What I suggest is you put your thoughts on chat also, because for some reason I'm unable to see all of you. Please chat, put it on chat, and we can see messages on chat. Now, they say this is not enough. There are a lot of other things also happening in the body. What they found is that there's a lot of association of pain and suffering with anxiety, fear, and a social isolation. A lot of overlapping brain circuit. You'll be noticing, like as we discuss more and more in terms of medications, a lot of medicines which we use in pain is also used by psychiatrists. There are many psychiatrists in this group, I'm aware. So I'll be very curious to hear their viewpoint on as we go along discussing, because we want to learn from you. But what they found, they did some studies where what they did, there was a group of monkeys, herd of monkeys, and they separated one monkey from the group, and they just forcefully removed that monkey from the group, and they studied the brain, the mapping. They did the mapping of the brain to understand what happens when a monkey is separated from its main group. And what they found, that this activation of the pathway which we normally see when there's a fear, anxiety, or isolation, the same pathway got activated when the monkey is painfully taken away from the group. So what it signifies is that there's a strong association of pain or suffering with social factors such as social isolation, and or emotional factors like anxiety, fear, like that. So there's a lot of overlap of all these factors. So more and clinical, like I said, clinical significance. There's an interplay of pain and emotional and social. When you talk about managing chronic pain, we have to remember that it's not just about giving some morphine and taking care of pain. If you really want to give total pain relief to the patient, you have to, of course, address the physical aspect of pain. Your pain management will not be complete if you don't address to other components of pain. It's so interlinked and so connected to each other. Unaddressed physical pain can lead to more of social pain, emotional pain, spiritual pain. And over a period of time, what happens, many of these chronic pain conditions, sometimes the primary cause of pain becomes less. This circle becomes smaller, whereas other circles become bigger and bigger and bigger, and they suffer. So however, how much medicine you give for his pain relief, he may not feel pain free because his other dimensions are so profound. So that's the reason when you talk about total pain or total suffering, And when you want to help those patients, we have to address to all the dimensions of pain. Any thoughts, questions? Just give me 1 minute. I will just want to check with Vinila if I can see the participant. Maybe I'm missing out on something. I'll just take. Hello. So coming back, so Vinila is trying to see whether we can do something about it, seeing the view part of it. So this is what we call it as this concept of total pain. So the pain is not just physical. You have to address to emotional, social, and spiritual pain. Let's try to define pain now. Now, based on this understanding, and now this again, this definition I've taken from International Association for the Study of Pain, which came in, this is a very new definition. Original definition was little different. They modified the definition it's only last year. What they said, pain is an unpleasant sensory and emotional experience. Because when you experience pain, it's not just sensory. Suppose I'm giving you a pinprick. What you feel as a pinprick, it's not just that sensation there, but also you feel some emotion which comes with that. So they say that pain is an unpleasant, first of all, sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What they're saying here is they're trying to say is that sometimes the tissue damage may be there. Sometimes you don't even see the tissue damage. It may be there with this potential tissue damage. Classic example I would say is that same like intervertebral disc prolapse. Originally, maybe when you do MRI, you may find some disc prolapse signs, but the way the patient will describe pain all over the body, he starts limping. Sometimes he will not even get up from the bed with so much of severe spasm and pain that when you look at the disc prolapse, it may be very small, and this will be pain experience will be so much out of proportion to actual tissue damage. So that's what they try to define in this, that sometimes the tissue damage may not be, it may look like that, it may not be real tissue damage, what we perceive. But forget about all that. When you're managing pain in your clinic, in chronic pain, what you have to remember is that pain is what patient says hurts. Forget about the definition. For all practical purpose, when you're managing pain in your pain clinic, now we expect that tomorrow, if you're running a palliative care clinic, you may be expected to see a lot of pain patients. And a typical pain clinic, when we do pain management, it's not so much, we don't have any medicines which other specialists may not have. It's the whole approach that how we see pain, a patient in pain, and how you assess the patient in pain and how you manage. That approach is different, but medicines are the same. I'm not going to teach you here some medicines which you are not already using it. But what we're going to look at is that how you approach the whole business of pain. And to do that, the first thing you have to understand is that take what the patient says hurts. If the patient says, I got pain, the patient has got pain. And then it's your job to understand why the patient is describing so much pain. Often when say patient says out of proportion pain, we say, oh, he's trying to attract attention, he's trying to malinger, like he's trying to asking for leave. We give some reason to it. But as a pain physician, what I would say is that believe in what patient says. If the patient says it hurts, it hurts. Take a step back and understand what is the cause. Is it the cause is physical? What are the emotional, social, and spiritual reasons? Or what are the other reasons that he's experiencing so much pain? He's coming to you because he's suffering. He's not enjoying coming to you. So when the patient comes to you in pain, believe in what he says and then make a sense of it. The last part of this pathophysiology, again, based on pathophysiology, we try to classify pain into two types: nociceptive pain and neuropathic pain. Nociceptive pain is whenever there's when I remember I told you these are the pain receptors, free nerve endings. When you give a pin prick and the impulse is generated and you perceive pain, that is known as nociceptor pain. And these receptors are known as nociceptors. Nociceptors means the receptors which respond to noxious stimuli. Bad stimuli, noxious stimuli, that's why they are known as nociceptors. And the pain produced because of the stimulation of these nociceptors are known as nociceptive pain. And neuropathic pain is abnormal neuronal pathway, any abnormal neuronal activity anywhere along the nerve pathway, any abnormal neuronal activity. Suppose there's abnormal neuronal activity here, that is known as neuropathic pain. This broad classification is very important to understand, because when you talk about management of nociceptive pain and neuropathic pain, sometimes we may have to take a different approach to pain. That's something we have to understand. Any questions here? So far, what we discussed? Any questions? So what she's saying is I had to click on the participant button on the bottom of the screen. I don't know. She's saying, asking me to.
Ma'am, am I audible?
Yes.
Ma'am, what you can do is that click on the participants button. You can see on the at the bottom.
I got the participant list is there. I
Yes,
got the
yes.
list. Yeah.
Then you can, apart from that participants box, click anywhere, double click anywhere on the screen. You will see that there is a list of participants on your right side.
No, when I'm doing that, my screen is moving. The screen sharing is happening.
Okay, ma'am, that might happen because of the screen sharing.
Okay.
Possibly
Yeah. Yeah.
because.
Okay.
So once you close the screen sharing, you can do
Very
that.
difficult to, like, I don't know whether I'm speaking to is moving so blank. Anyway, thank you.
No, no,
Sure.
no problem.
Yeah. Okay. So we're done with this pathophysiology. I think this is the most difficult part when you're discussing chronic pain. Then we are moving on to the more practical part of managing pain. So just to recollect pathophysiology, chronic persistent pain means a pain persisting for more than 3 months. That's what we call it, chronic persistent pain. And now we understand that if the pain is left untreated, or if you don't give good continuous analgesia, it can lead to a lot of changes in our body. And this is known as neuronal plasticity. And there's changes like peripheral sensitization, peripheral recruitment, central sensitization, central recruitment, and there's a reflex spasm, and all this, and muscular spasm, vascular spasm, and genetic changes, which when the change becomes irreversible, and all this leads to permanent changes sometimes. So earlier the pain is treated, the better. And pain is not just physical. Other dimensions of suffering like emotional, social, and spiritual pain can also add to the suffering. So we have to talk about this concept of total pain. And definition of pain, when pain is what patient says hurts. When the patient says I've got pain, believe in the patient. You and believe in what patient says. Next, what we're going to do is we are going to look at the pain assessment part of it. I'm still not very happy with how we are moving. Let me find out if they do the screen sharing. Maybe I'll be able to see you. Let me see if I can do that. Vanilla, if you do the screen sharing, can I see the participants? Because right now I cannot see the participants. I just try that. I'll stop screen sharing. Yeah. Yeah. So I'll just stop screen sharing and let's see if Vanilla can do it for me. At least I see the see, I can see all of you. Otherwise, I was just looking at blank screen. I'm trying for Vinila to help me do screen sharing so that I can see you and yeah, continue the discussion.
Ma'am, meanwhile, you can just ask them if they have any questions. I'm just loading, sharing
Yeah,
the PPT.
we'll wait. Because of this breakout, I think this little confusion. Normally, we are able to screen share and also see participants. I think both together we are able to do.
But we can see the screen share and all the participants from
You
our
can see,
side.
huh? I think from my maybe my laptop problem. I think.
You have to select the standard view.
Maybe view option, I think. Yeah.
View option, there are side by side, gallery view, and the standard one is you can see them in the top.
Speaker view, gallery view. No.
Gallery view.
Yeah. Gallery
Then
view.
you will get a small panel of participants.
Yeah. But when I'm screen sharing, I don't know whether that remains. Not sure.
But that is a separate pop-up window. You can move around your screen and keep it wherever possible.
Yeah, that's how I used to do. Like in my previous laptop, it's just a, yeah.
I use the same MacBook. I can do that.
Yeah, now I think I'm getting it. Let me try again. Now screen sharing. Let me try again.
Yes, ma'am, I'm ready. Just let me know if you can't.
Yeah. Let me try again. Huh?
Grouping DT form the DT form
No, still I'm not getting it. It's okay, Vanilla. We won't waste time. Please do it.
Okay, ma'am.
Yeah.
Can you just tell me the number of the slide? No?
Assessment. Come to the assessment. Just one blank slide is their assessment. Yeah, go back. Yeah, assessment. Thank you, Vanilla. So now the next maybe few slides will focus on just on the assessment part. Like I said, when you have a pain clinic and you're seeing patients with chronic pain, different kind of chronic pain, the core, the most essential component of your management of pain is starting with a good assessment. I'll give you an example why. Like we'll make a sense of it when we see this patient. Next slide. Now here we have a patient 32-year-old, cervical cancer, advanced cervical cancer. She has got cancer in the cervix and she complains of severe pain in the low back, radiating to the perineum and the thigh. She says, I got severe pain, back, perineum, and the thighs. Why do you think she has pain? Can you think of some causes of pain? You can chat, put it in the chat, or you can just directly speak. What are the causes of pain?
Bone mets and
Bone mets. So probably cancer spreading to the bone, back pain, could be explained by the pain in the going to the bone. Absolutely. Any other cause of pain? Any pain which you can think of? Cancer cervix, pain in the back, radiating to the perineum and thighs.
Infiltration of the infiltration to the nerve.
No.
Nerves, absolutely. You're very right. So suppose the cancer is growing because it's advanced cancer. It's very common what we see in this kind of situation. The pain, the cancer grows into the sacral plexus. This is what the most common presentation, cervical cancer patient. As it grows into the sacral plexus, you get this pain, typical classic pain in the back. And that because of the nerve involvement, you also get this radiating pain to the thighs, which we see. So this is a classic example of neuropathic pain, and often happens because of the involvement of sacral plexus. Yeah. Any other cause of pain?
Perineum muscles stretching the cervix.
Suppose local muscular involvement. So normally you're talking about the surrounding structure involvement. It can be the muscle itself, which can cause perineal stretching and perineal pain. Yeah. And what surrounding structures, other structures can they have? Simple. I'm like, there's no big thing about it. What other thing can they have? It can be bladder and rectum, and it has a lot of painful dysuria and painful defecation. All these things can happen, and that is that can also cause pain. Yes, the surrounding structure infiltration, and this can cause pain. Any other cause of pain? Emotional, very excellent. So we discussed that. Remember the 4 circles? It could be emotional pain, like young lady, and doctor has told her advanced cancer, and she's in terrible pain. So what emotional status she must be in? She must be suffering so much. She must be feeling so bad about what's happening to her. So a lot of emotional distress, increasing the physical aspect of pain, and it all very interlinked. Yeah, absolutely. Any other cause of pain? Yeah, so kind of if you see, as you said, just I asked you this question and you came up with so many reasons of pain. So like I will kind of put my thoughts into it. Next slide. Next slide. So like I put my thoughts, the cancer per se locally, the cancer itself can release a lot of chemicals locally, and it can cause severe pain. Like you said, it can be neuropathic pain, it can be bone involvement, surrounding viscera, and often sometimes local infection. The cancer wounds can be badly infected, and it can itself cause a lot of inflammation and increased pain. So this can be so many causes of pain. Do you think in the same patient you can have more than one cause?
Yeah.
Absolutely, yeah. You can, it's not that only neuropathic pain or only bone. It can be combination of many things. And this is typical which we see in cancer pain. Cancer pain, often there are more than one cause of pain. This combination of pain. So why is it so important to understand this?
Yes.
How is that going to help us understanding this? So what? Okay, she's got neuropathic pain, she's got bone pain, she's got infection. Yeah,
Pain relief.
Because what drugs we are going to give.
absolutely. So once you understand, like I'm not focusing on only the physical part of it now. As one of the doctors mentioned, emotional pain. I'm not touching on that right now. Even if you look at just the physical part of it, the physical cause for everything, are you going to write morphine? No, that's not going to be helpful. As one of you mentioned, it could be muscular pain. If it is skeletal muscle involvement, do you think morphine will help? Suppose you wake up in the morning, sleeping in a very abnormal position, and you get neck spasm, severe pain in the neck. Often, sometimes we get up and we feel that. Do you take morphine for that? What you need
No.
is a nice anti-inflammatory and muscle relaxant there.
Awesome.
Yeah, and suppose you have neuropathic pain, there are certain medicines which you use exclusively for neuropathic pain. Bone pain, again, there are some other, we have to think about what is that we can do for bone pain. Infection, when infection is there, I'll treat infection. Yeah, suppose there's an add-on constipation. Very often these patients experience a lot of constipation. So I'll relieve constipation. So that's the reason when I say a good pain management starts with the strategy of good assessment. Why? What is happening to the patient? What is the cause of pain? And you understand that, your management approach will be so different. Next slide. So many good centers, they say they consider pain as a fifth vital sign. They say the quality care means pain is measured and it is treated. If you understand what is happening, there's a high chance that you will treat the pain. Sorry, I'm getting this call again and again. The pain is measured and treated. So it's considered as fifth vital sign. Normally in case files as a nurses, we ask the nurses to take vitals. We say pulse, blood pressure, temperature, and respiration. In many good centers, accredited centers, they also have pain as a fifth vital sign, because the nurses are writing down 8 out of 10 pain. Then as a doctor, when you're doing your rounds, you'll, wow, 8 out of 10, then I have to do something about it. You'll address the issue then. That's the reason they say measure pain, and it will help you in the management. Next slide. The assessment can be self-report, which they say is a gold standard. Even for a patient, your child, we say gold standard is self-report. A child, ask the child or ask the patient, and they will tell you. Then, of course, observation. So, for example, you're dealing with patients like dementia patients. They may not be able to express. So how will you measure pain in such patients? Observation. There are many scales for such patients. And then physiological, what you typically see in critical care when the patients are totally unconscious or infants, we talk about physiological pain. Next slide. I'll just give you, normally, this is something we encourage our nurses to do it, but even for us, it will be very useful. And this we use acronym, many acronyms are there, and I'm sure when you take history, you do that. But once again, going through this, PQRST, patient self-report, and what increases the pain, what decreases the pain, what is the quality of pain? Can you describe the quality? Where does it radiate? Is there any radiation? How severe is the pain? For how long have you been having this pain? So this is what this we call it PQRST. And in a typical pain assessment, we also add what we call it as, next slide, +2. What is this +2? Have you tried any medicine and has it worked? Number one. And second is, how is the pain affecting the quality of your life? This is a very important question, because when you talk about chronic pain, often how much the pain is impacting your life, your mood, your mobility, the child, if it is you're dealing with a child, your play, your appetite, your sleep, and simple thing like activity of daily living. Now this lady, if you see, obviously her whole life, activity of daily living is affected. Very obviously, so much of pain, the posture, if you see her, posture, it just shows that so much of pain. So when you talk about pain assessment, you ask all those regular questions. In addition, we often ask this question: how has it affected your life? Tell me about your sleep. Tell me about your mood. Tell me about your activity of daily living. It gives you a lot of information about the impact the pain has made on patient's life. Next slide. We use, when I say measurement of pain, we use different scales. Vinila, do you want to give them 5 minutes break? Because 1 hour they've been sitting continuously.
Yeah, so
Come
if
back.
we say, yeah, maybe we can give them 5 minutes break, ma'am, no issues.
So I want to come back to this measurement of pain a little more in detail. So
Sure.
just come back. You can just stretch yourself, get some water, and come back in 5 minutes time.
Yeah, so it's now 4:03. So we'll come back by 4:08.
Yeah.
Yeah.
Thank you.
All doctors kindly note.
Yeah.
Thank you.
Okay. Okay, thank you.
Yeah.
Thank you.
Hello.
Yes, ma'am.
Hello.
Welcome back. Yeah. So now next few minutes, as a part of assessment, let's focus on how to measure pain. So why do we need to measure pain? Suppose when I take temperature, I say this patient has got 98.7 or 99. So we get a fair idea of what is the patient, whether the patient is having fever, how bad the fever is, we get a fair idea. Similarly, when you take blood pressure, we say 120/80. So we get an idea of blood pressure. Similarly, when you measure pain and the patient says, somebody says, I got this much pain, What is it? Why do we need to know that? Suppose this much quantity pain. Why do we need that? How does that help us?
To decide on pain relief,
So one is
the dosage, and
absolutely.
mode.
Yeah, somebody says how much dose to give, and what is the response to your treatment? Yeah, as you said, how much pain relief you got, and what medicine to use. We'll come to that as we discuss, like what medicine to use. So we'll get an idea, like, okay, with this kind of this much pain, this is the medicine may be more useful. So we'll come to that.
Hello, ma'am. Did we lose you? Hello. Rest all the participants, can you hear me?
Yes.
I think we lost
Yes,
Dr.
ma'am.
Gayatri.
Yes.
Yeah, I think we lost Dr. Gayatri. Just a second.
Yes, yes.
Hello. Oh, sorry.
Yes, madam. Yeah.
Totally, this side is a lot of disturbance this time. I'm extremely sorry about that. So, like all of you very rightly said, we need to measure pain for to decide what is the dosage, what medicine to use, and what is the response to your treatment. And so that's the reason sometimes it's very helpful to understand how much pain. Now, the pain, suppose imagine yourself. Suppose I give you a pin prick. I have a pin. I'm going to prick you. And I'm going to ask you, how much is your pain now? Do you think it's very easy to describe? How much pain you got now? It's not easy, isn't it? So when I'm giving you, when you get pain to say, okay, I got this many kilos of pain or this many grams of pain or numbers, it's not very easy because it is not easy. Pain is very subjective. What you may experience as one of you, suppose I'm saying Dr. Puvikaran is experiencing, suppose for the same pinprick, I have Dr. Paul Bright and Dr. Puvikaran. I'm giving the same pinprick. What Dr. Puvikaran will experience will be very different from what Dr. Paul Bright will experience. So both of them are going to experience for the same pinprick different kind of pain. Now, for example, Dr. Puvikaran had a very busy night. Whole night he was in the COVID ward, managing COVID patients, and he has now come for the class. Very tired and exhausted, but he has to attend this class. And Dr. Paul Bright, he's had a nice sleep, well slept. Morning, he had a nice breakfast, lunch also. Now he's very relaxed and he's come here. I give you again pinprick. Who will experience more pain, Dr. Puvikaran or Dr. Paul Bright? The doctor who underwent night duty, busy night duty, exhausted, did not get sleep, he will experience more pain, or the doctor who slept well, had nice food, relaxed, who will experience more pain? Yes, Dr.
Yeah, unmute yourself.
Relaxed
please.
one.
Hello?
Albright might have more pain.
Sorry?
Albright might have more pain.
More pain, yeah, because
Yeah.
pain is, remember that pain is so much influenced by so many other factors, like your sleep, your appetite, your mood, how relaxed you are, or many other factors like your your emotional status, and of course many other medications, your disease. So many factors influence pain, and so pain is very subjective. I cannot say that a patient with cancer stomach will always have this much pain. So it will be so different for patient to patient. So when you score pain, let's understand It's not going to be easy. So when you ask your patient how much pain you got, don't be surprised if they can't tell you. So be prepared for that. But still, sometimes we try to score pain, and we manage to get some fair idea about patient's ability to tell you how much pain. Now, the fact that it's not easy to measure, when you go to your book or any website where you look at different ways to measure pain, you will find hundreds of scoring system, because it is not so easy. It's not straightforward. It's not like blood pressure or fever. So when you look at, so I'm going to touch on some common scales which we use to measure pain. The most common is numerical rating scale. What we say is that, suppose you just told me you got pain in your legs. I want to know how much is your pain. Suppose I say 0 means no pain and 10 means maximum imaginable pain, worst imaginable pain. How much is your pain in the leg? This is what we ask them. Remember that it is a patient who is going to score, not you. You cannot say, is it 4? It doesn't look that bad. I think it must be 2. It cannot be you who will be doing it. You will ask the patient will tell you how much is the pain. So this is what we call numerical rating scale, 0 to 10, or sometimes they say more, they understand percentage. Sometimes they say percentage. So we'll ask them, how much is your pain? Now, many patients may not have ability to understand numbers. So if you ask them 0 to 10, 1 means no, little pain, 2 means more pain, 10 means more, they will become more anxious if they don't understand numbers. So you must have some other ways to measure pain. So next slide. The other scales which we use are, another thing is what we call a visual analog scale. So here, what we do is we just ask the patient to move, suppose we have a 3-dimensional structure where we ask them to move the bead on a scale. We say, move the bead. This end means no pain. The other end means severe pain. Just move your bead and tell me where is your pain now. So they will just move a bead on the scale and they put the bead wherever they think it's, depending upon how they feel. And behind we'll have the scale. So when we look at the score, will be there at the back, and by wherever they leave the bead, we'll have a score on the back. This is known as visual analog scale. Next slide. This is another method, severity assessment scale. Simply we do it with numbers. We say, tell me whether you got mild pain, moderate pain, severe pain, excruciating pain. Mild, moderate, severe, excruciating. Now, this is much more easy for many patients to understand. But you have to ask these questions in your language. The important thing is that how you use your own language to ask this question. So how will you put that in Tamil? Mild pain, moderate pain, severe pain, excruciating pain. Can someone volunteer? Mild pain, Tamil? Vinila, how do you say in Telugu?
So in Telugu, generally, usually we say that కొంచెం నొప్పి, ఎక్కువ నొప్పి, చాలా ఎక్కువ నొప్పి.
Like unbearable.
భరించలేనంత నొప్పి.
Yeah. So try in Tamil. It will be similar. కొంచెం నొప్పి. Similar in Tamil.
Sir, teach us, sir, Tamil, how to ask pain.
கொஞ்சம் பெயின்
Yes.
ஓரளவு கூட,
Yeah.
சரியான பெயின், சிவியர் பெயின், சரியான கூட,
And unbearable.
தாங்க இல்லாத பெயின்.
Yes. Simple. So if you don't use this in your own language, patient will not understand. If you say mild pain, moderate pain, but they may look at you. So practice whatever we are discussing in your own language. So this is known as severity assessment scale. So numerical scale, visual analog scale, severity assessment scale. Next slide. Sometimes a patient, they just don't understand these things. They become very anxious. They think doctor is asking me something, I'm unable to express. They become very anxious. So what we simply say, forget it. I don't know how the coins, I don't remember Sri Lankan coins, but in India we have 25 paise, 50 paise, 75 paise, 1 rupee. So we say, how much is your pain? 25 paise, 50 paise, 75 or 1 rupee? That they understand very quickly and they'll tell you, oh, this much, I got 75 paise pain. So Again, you have to ask in Tamil, in your own language, how this paisa. Telugu, what is the number, Vinila?
So generally, like here, all our people will understand Rupai. So 25 is Paula. So first we explain to them that Paula ante koncham noppi, రూపాయిలో పావుల అంటే కొంచెం నొప్పి. 50 అంటే ఆఠాన, దానికంటే ఎక్కువ నొప్పి, సగం నొప్పి. 75 paise, ముప్పావంతు నొప్పి, like kind of 70%. 100, it's like we say రూపాయికి రూపాయి నొప్పి. So full pain, unbearable pain.
So yeah, so you have to use this. So you have to use in own language, this same. So you have to decide. Yes, Dr. Krishnalingam, I see one hand going up.
Yeah.
You want to add something, Dr. Krishnalingam?
No.
Yeah, your hands went up, so I was wondering. Yeah, so these are the different ways. But the idea is that for somehow, if you can get to know what is the severity of pain by some means, and it will be very useful when you manage pain. So yeah, next slide. In children, sometimes these things may not make much sense. Many centers where they see children, pediatric patients, they use different kind of scales. So smaller children, it's different. This kind of scale is very useful for 4 to 8-year-old children. We call it as faces pain scale, where they ask the child, do you hurt? Are you in pain today? How is your pain? Is it like this, or a face like this? Tell me, how do you place yourself today? Like this, which is we call it as faces pain. Next slide. Now we also try to, and I'm sorry about this drawing, little not all right, but we call it as pain mapping. Pain mapping means we try to, I told you, like a syndrome like cancer pain, often we have more than one type of pain. So it's always very useful if you can map it on the, we call it as body chart of pain mapping. So where exactly is your pain? Now, if you look at this pain, the patient, this lady, suppose we should have a female patient, suppose, and the patient, she says pain in the thigh, which is 9 out of 10 in the numerical rating scale, burning, constant pain, and it's radiating to the thigh. And this was scored on 18th March 2021. And she also describes another pain, which is in the back, low back, which is 7 out of 10, constant dull pain. Now, this patient, if I see today, this was a month back, and today I'm going to see her again. When I see her, I'll say, last time when you came, you had this pain, which was 9 out of 10 and 7 out of 10. Do you have the same pain today? She'll say, no, that pain I'm much better now with medicine. I got another new pain, which is there in my head. I'm getting in a headache. So then you realize, okay, this is a different pain we are not talking about. So this kind of pain mapping is very useful. So most pain clinics, they always have these case files with a body chart, and they do this kind of mapping in detail. They look at where all the patient has pain, and they go and they mark it like that. So in the parallel nurses session, they're going to spend a lot of time trying to learn to how to map pain, and so that it's very useful for subsequent follow-up of the patient. Next slide. Let's come back to the same lady, 32-year-old lady with advanced cervical cancer, complaints of pain in the low back, radiating to the perineum and the thigh. And now we are kind of understand what she's experiencing. But she says, I got severe pain. She scores 8 out of 10. She says, I got 8 out of 10 pain in the back, and the thigh pain is 5 out of 10. Back pain is more severe, 8 out of 10. Thigh pain is 5 out of 10. And this is how she describes. Next slide. And when we look at the prescription, she's on this prescription: tramadol 50 milligram twice daily, injection diclofenac, intramuscular injection, SOS. Now I want your input. Do you see any problem with this prescription? A prescription given to a patient with advanced cancer who complains of 8 out of 10 pain in the back, and another pain 5 out of 10 in the thighs, and the patient has been prescribed 50 milligram twice daily diclofenac intramuscular SOS. Do you see any problem with this prescription? I want some responses.
antidepressants கொடுக்க வேண்டியிருக்குது.
Sorry?
His pain management is not adequate.
It's not adequate. She came to you. Now she is on this prescription and she describes, after taking this medicine, I'm still having 8 out of 10 pain in the back and 5 out of 10 pain in my thigh. She has tried this. Is there any problem with this prescription? What you see? Is it a good prescription? Do you want to challenge this prescription?
No, most of the time, this prescription cover the muscular skeletal pain, not the neuropathic pain.
Okay, what you feel is that diclofenac is more for musculoskeletal kind of pain, and tramadol may be, and where you are not very sure whether neuropathic pain management is well covered in this, so that is not addressed properly. Yeah, and I also see dosage not written properly. But yeah, I totally agree. The 50 milligram twice daily they have written. Diclofenac, how much dosage is not given, so it's not a very good prescription. That way, it's very bad prescription when you don't mention dosage properly. Anything else not so good about this prescription?
Is it practical to
Frequent
give it?
dosing,
Sorry?
and it is only twice daily, but
So
there
tell
should
me.
be a intermittent pain analgesic as well in between timing to
Absolutely. I totally agree with you, Dr. Paul Bright. Tramadol works for only 6 to 8 hours. Remember, I said chronic pain, chronic persistent pain. The pain, if you someone is having chronic pain, you have to give the medicine according to the duration of action, round the clock. So when you give 50 milligram in the morning, what will happen after 6 hours? The patient's pain will come back, and then patient will suffer for a few hours before the patient takes the next dose. So that's very inhumane, actually, what you're doing. So that is not acceptable. So the dose frequency is not adequate, because based on action, at least the patient should get 50 milligram 3 times a day. That's the minimum, or not, if not 6 hourly. Yes. I saw one more response.
Is inward management or
Sorry?
is inward management? The prescription is given in the inward for the inward patient or outpatient?
That's a good question. Tell me more about it. See, any chronic pain, the patient is not going to be in the hospital forever. Do you think this patient will remain in the hospital forever? No. Patient has to
Oh.
go home.
So
What is
giving
their problem?
giving injection is giving
Absolutely.
injection.
It is not a good idea to give this kind of prescription for someone. Some chronic pain, patient will need medicine round the clock for long duration of time. So when you write injections, where will they go and take it? So it's not at all recommended in chronic pain to give injections as an option. You can do it in acute and chronic. Someone comes with acute pain state, you give, settle the pain, and then he should be put on medication which he can take in the home. So I totally agree with you. And not only that, diclofenac, when you give, often it needs to be given deep IM, intramuscular. And most of our patients, especially when you're dealing with palliative care patients, their muscle bulk is very less. Emaciated patient. When you write intramuscular injections, these patients have more chance that it will be more painful, A. Second, this chance that it damages the underlying nerves and other structures, and it can cause more harm to the patient. So normally in palliative care, we don't write intramuscular injection. It's never indicated. We go for either intravenous or subcutaneous. We'll come to that someday. One of these teaching sessions will have subcutaneous route of administration. In palliative care, we avoid intramuscular as much as possible. So I totally like your point about giving injections intramuscular for these kind of patients. We'll come to more of this. We'll be critical of this prescription, but this is a standard prescription which we see in many hospitals, many practices. So when remember that, like I said earlier, I'm going to repeat this again. When you set up a pain clinic, what you do is the whole approach, not the medicine so much, what you're going to use, the whole approach. So remember some of the principles which we try to follow when we manage chronic pain. Next slide, Vanilla, is giving the drug by the mouth, by the clock, by the ladder. Remember these 3 principles. There's one more principle we say, Individualize the patient. Each patient is different. You cannot standardize that all patients with rheumatoid arthritis will get this pain, this much medicine. You cannot do that. Each patient is different. So what is that by the mouth, by the cloth? By the mouth, like I said, chronic pain, they're going home. So plan a medicine which they can take orally or the least invasive. If it all sublingual, fine, but it has to be least invasive because they have to take it every day round the clock. Second principle is by the clock. So it's very inhuman when you give one medicine in the morning and then say next dose is only in the night. What will happen in between? He'll suffer because the baseline pathology is persisting. So you have to give drug by the clock. Third is what we call is by the ladder. We'll come to that, what do you mean by the ladder? So these are the three principles, and fourth principle, individualize the treatment. That means each patient is different. Next slide. So somebody tried to correct the prescription and the patient was put on diclofenac 50 milligram 3 times a day, tramadol 50 milligram 3 times a day. Still pain is not better. Now, if you see, patient has 3 times a day properly given prescription with the proper dosage, no injections. Pain is not better. What to do? Patient has severe pain in the back radiating to the leg. What next?
Add one more painkiller for the
Like?
neuro.
Okay, that's a good
Consider the
idea
neuro.
because you're suspecting neuropathic pain. So Dr. Sakti Balan says, why don't we add some more, some other adjuvant, we call it as adjuvant medication for specifically for neuropathic pain, like?
Pregabalin.
So you're adding some anticonvulsants like pregabalin or gabapentin or tricyclic antitussive. Yeah, we can try one of those things. Anything else? Any other suggestion? I see may need to add totally. Dr. Shobika, I agree. I see that Dr. Shobika is very particular about writing prescription, right dosage, right frequency, and also adequate prescription. And Dr. Shobika says, how about adding omeprazole as a gastroprotection for diclofenac? Sorry, I see some other comments. And assess the psychological aspect. Please, I totally 100 marks there to Dr. Krishnaswamy because every patient, that umbrella of psychosocial and spiritual support will always be there, whether using diclofenac, tramadol, or any fancy medicine. Don't forget this part of addressing the psychosocial and spiritual part of it. Totally accept that. Excellent. Yeah. So now, next slide. I just want to quickly touch on this ladder part of it. I remember I told you 3 principles: by the clock, by the mouth, and by the ladder. Now, this is the famous ladder which we talk about. This ladder was introduced by the World Health Organization. Originally, it was used for cancer pain, but then now they also talk about the same ladder which we can use for all chronic persistent pain. It consists of 3-step ladder: step 1, step 2, step 3. Step 1 means non-opioids. Step 2 means weak opioids with non-opioids. Step 3 with strong opioids and non-opioids. This is a 3-step ladder. Now, non-opioids means we mean paracetamol or diclofenac. We'll come to weak opioids and strong opioids, but usually second step is continuing non-opioids with weak opioids, with or without non-opioids. Step 3 is instead of weak opioids, we add strong opioids with non-opioids. Simple, it's a very simple approach to manage pain. How to choose the ladder, whether to choose step 1, step 2, step 3. We can go up gradually. Suppose you start with step 1. This is what we did in that patient. Where is that patient now? Patient has got diclofenac and tramadol. Which step of the ladder patient is right now?
Weak opioid.
Weak opioid. So patient is on tramadol and patient is on diclofenac. So patient is here somewhere. Patient's pain is not better. So as per the approach, they say the patient pain is not better, move up the ladder. So here we'll, instead of tramadol, we'll add some strong opioids and continue non-opioids with or without. You need not always add non-opioids, but we can go up the ladder. So how do you define the step of the ladder is based on the severity of pain. Remember that. Mild pain, step 1. Moderate pain, step 2. Severe pain, step 3. Now, it is not like once you go up, you cannot come down. It's a up. You can easily go up. It's a sliding scale. You can go up and come down. Now, for example, sometimes we see a patient first time coming to your clinic with a huge mass in the neck, and you're still investigating. You're sending the patient for biopsy or scanning, and meanwhile, the patient is in severe pain. We still don't know diagnosis. Which step of the ladder will you choose? Patient has got severe pain, neck swelling, so we don't know what's happening. Which step will you choose? Severe pain, so we choose step 3. Patient has got advanced cancer, almost in the terminal stage of illness, and patient has got very mild pain, not much pain. Which step of the ladder will you choose? Step 1. So mild pain, step 1. Moderate pain, step 2. Severe pain, step 3. Mild pain means suppose 0 to 3 on the numerical scale. On the scale, the patient says 4 to 6 score, moderate pain, we use step 2. 7 to 10 means severe pain, step 3. This is how you choose the ladder. Now, this is not depending upon the stage of the illness. Please remember that. Whether you're late stage or early stage doesn't matter. It is severity of the pain which decides which step of the ladder. Now, suppose a patient who came with huge mass in the, he has got a mass in the neck, you're sent for biopsy and scanning, and patient is in severe pain, you started on step 3 of the ladder. Your biopsy report comes and it's found to be lymphoma, and you start the patient on chemotherapy. The mass completely disappears. Just small amount of mass remains, and patient says, now my pain is very less, it's only mild pain. What will you do? Quickly, you come down the ladder. So you will, from the strong opioids, you stop strong opioids, maybe just leave the patient on non-opioid. So this is what I say, severity of pain which decides the moving up or down of the ladder. And this is the simple approach we use for managing chronic persistent pain, which was introduced by the World Health Organization. And as one of you mentioned, don't forget this umbrella. I'll put it here actually on the top. At every step, of course, you have to address patient psychosocial and spiritual issues. That should go along every step. Any questions so far? Okay, next slide. Little bit about, not going to take a lot of time. We got only maybe another 15 minutes. Non-opioids. When we say non-opioids, we say it includes paracetamol and non-steroidal anti-inflammatory drugs. I'm not going into detail of it. I'm sure most of you so familiar with its usage, you must be using it every day in your practice, whichever specialty you're following. So, but still I'll touch upon that. Non-opioids means, like I said, paracetamol. Next slide. So normally when you use paracetamol for pain, it's not as an antipyretic, more as an analgesic. Again, paracetamol has its central prostaglandin inhibitory action. How does it work? This is how it works. And they say the recommended dosages start with at least 500 milligram 6 hourly for pain relief. It's not like for fever. It's for pain. So give a good dose. And many patients, when you can't use an analgesics, paracetamol is a wonderful analgesic. When you can't use NSAIDs, it's used a very wonderful analgesics, very good for patients having inflammation. Now, for example, I got a patient with leukemia, and patient bleeds into the joint. Patient has got severe joint pain because of bleed. There will be a lot of inflammation, isn't it, because of the bleed. Now, I cannot use NSAIDs because the patient's platelet is very low because of leukemia. His platelet is only 20 or 30,000. So obviously, I can't use NSAIDs. So what will I use then? I'll use paracetamol. It's a wonderful alternative to NSAIDs when you're not very sure whether we can use it or not. So this is the dosage which we use. Next slide. Non-steroidal anti-inflammatory drugs. There's a huge range of anti-inflammatory drugs available in the market. You all must be having your own favorites, isn't it? Which is your favorite? Which is the most commonly used NSAIDs in your practice? Name a few.
Diclofenac sodium.
Diclofenac sodium. Others? It's the same or something else also used sometimes? You must be having your own favorite.
Ibuprofen.
Ibuprofen? Yes. Ibuprofen. In fact, ibuprofen, they say, is one of the most well-studied NSAID in the population. It's not something new. It's the most well-studied medication in the population among NSAID group. So ibuprofen, yeah. There are many others. I'll come to just quickly come to that. Just to understand, next slide. When we, all of you so used to using NSAIDs, but and there's also this lot of discussions about selective and non-selective inhibitors. So I'm sure you must be very familiar with this pathway. Like this is arachidonic acid, and you have leukotriene pathway, you have prostaglandin pathway. And in the prostaglandin, there are two types of enzyme, COX-1 and COX-2. Cyclooxygenase 1 and cyclooxygenase 2. What they say is that cyclooxygenase 1 is an enzyme which is constitutive, which means that it is always there in the body, and it is required for production of prostaglandin in the end organs like kidney, platelets, and GI tract. You need that. Prostaglandin in the kidneys to maintain vascularity, platelets for aggregation, GI tract for its integrity. You need prostaglandin. And the enzyme which is responsible for that is COX-1. COX-2 is the enzyme which is produced in response to inflammation. Normally, they say it's not so much there in the body. So they are released in response to some inflammation, and they are known as COX-2. And they are produced. So suppose I got a joint pain, knee joint pain. There's a lot of inflammation. Normally, I'll have COX-1 all the time in the body. But when I have some knee joint pain, osteoarthritis, and inflammation, COX-2 is produced selectively in the knee in response to that inflammation. So what researchers, and they call it as inducible enzyme. So what researchers said, why don't we produce, no, when we inhibit platelets prostaglandin or kidney prostaglandin, GI tract prostaglandin, you get this undesirable side effects. Like in kidneys, you develop kidney failure. Platelets, it prevents it. It produces bleeding. GI tract, it leads to gastric erosion, perforation, and the bleed. So this is because prostaglandin gets inhibited by COX-1. So that's the reason researchers looked at very selective COX-2 inhibitor medications, which will selectively block the prostaglandin only at the site of inflammation, not preventing prostaglandin release in kidney, platelet, or GI tract. So if you understand, suppose I got osteoarthritis, the COX-2 will block only the prostaglandin at the site of osteoarthritis, not blocking all other prostaglandin. So that's the reason that so many newer medicines came up about COX-2, around COX-2 inhibitors. And that led to a lot of revolution about use of NSAIDs. Next slide. I recommend that you read this little more in detail. But these are the examples of non-specific, which means all these NSAIDs will block both COX-1 and COX-2. These are also known as traditional NSAIDs and well studied actually. These are all very old, traditional, non-selective NSAIDs, and they block everywhere. And that's the reason when you have these NSAIDs, often we face problems which you typically see with non-steroidal anti-inflammatory drugs like gastric erosion and the complications and the kidney problems. Next slide. Partially selective celecoxib, meloxicam. I don't know whether you have it in Sri Lanka. Next slide. And very selective COX-2 inhibitors like etoricoxib. I don't know whether you have it there. So these are highly selective COX inhibitors. So when suppose coming back to the same patient, leukemia, bleeding into the joint, and I need to write some anti-inflammatory and non-steroidal anti-inflammatory medication after paracetamol, because I would expect that it will not inhibit platelet aggregation. And so it will be relatively safe in patients with leukemia, etorecoxib. But there are other issues which has come up with new highly selective COX inhibitors, like it's found to be very thrombogenic. So it's not recommended for long-term use. You must have heard rofecoxib, how it withdrew from the market. I don't know whether you heard of that, or it came up, it was there in the market for a long period of time. Suddenly it was withdrawn because a lot of thrombogenic activities was found with the rofecoxib. So, but generally this is what how its NSAIDs look like. Any questions? I saw one response somebody wrote when diclofenac was seen, why omeprazole was not written. Do you write gastroprotective agents for all NSAIDs? What is your protocol? For all?
Non-specific,
Yes.
for the
It is good.
non-specific, we write. For this partially selective and highly selective, normally I am not writing.
Yeah, so there's no right or wrong. It's just that we have to understand that, as you said, it may not be required so much for highly selective, but definitely we have to identify some high risk patients where we have to have gastric protection. High risk, like suppose the patient is on long-term NSAIDs, along with steroids, older people, bleeding tendencies, like all these patients, we have to be very careful when we write NSAIDs. So I would be worried not so much about the gastric problem. I'll be more worried about the renal cause, renal problem. Because if you have one patient developing renal failure because of your NSAID usage, not acceptable. So in many centers, they have done away with NSAIDs. They don't use NSAIDs in chronic pain. So even though it is one of the most freely available over-the-counter medicine, NSAIDs, world over, and most commonly abused, but people still use it. And they don't use it with prescription, just like that they use it. And many of them, they land up with a lot of this irreversible problems like renal failure. So you have to be very careful. And but when you're writing any gastroprotective agent, what is your drug of choice?
Omeprazole.
Yes. The drug of choice is proton pump inhibitor, both for prevention as well as for treatment of NSAID-induced gastric erosion is proton pump inhibitor. Remember that, not antacids, regular antacids or H2 receptor and blocker. It has to be proton pump inhibitor. But again, you have to be, I don't know whether how, because we have to think about when you write too many medicines, often it leads to poor compliance by the patients, because when you write 4 or 5 medicines together. So when you add one more omeprazole, so that's this whole debate. Do we need to write omeprazole for all the patients? And costing, you have to think about the cost because patient is going to buy and take it, and drug interaction. So all these factors you have to take into account when we write, just keep on adding medicines. All these problems you have, we call it as pharmacoeconomics and drug interaction. So be mindful of that when you add these kind of medicines. So next slide. I just one last slide I'm going to use, opioids in India. I'm just going to project this. And these are the common opioids which we have available in India, weak opioids and strong opioids. We are going to leave the breakout room. One last slide, Vinila, quickly. With these two questions. We'll come back to this next time. What are the commonly used pain medicines in Sri Lanka and what are the opioids available in Sri Lanka? Please make a list of these medicines and come back next time. I want to know the opioids available in Sri Lanka and commonly used other pain medicines, whatever medicines which you use in your pain practice. We'll compile the list and we'll come back next time.
Homework, madam.
Yeah, homework. So we'll read it out next time and then we'll take it from there.
Sure.
I will come back to the main room. Neela, you can wind up by any housekeeping announcement, like we're talking about sharing I'll share with you the main points and any resource if I have actually. going to share. Hello, Vinila,
Yes, ma'am.
you want to wind up?
Yeah.
Right.
Hello. If you have any questions to Dr. Gayatri or Terry, any one of you, you can just please ask them, or if you can raise your hand, or you can just type your questions in the chat. If you have any question. If you don't have any question, maybe, do you want to take a minute and then ask a question?
Yeah. I'll wait for the questions. What I'll say is that we'll be sharing with you the PDF format of our PowerPoint, number one. Number
Yes.
two, we'll be sharing with you some learning points
Learning points.
and also any important resource which you'd like to access to read about it.
Actually, we were speaking about a question and we got cut. I'm not sure if that person is here.
You can still.
Please go ahead. Sorry.
Yeah, I am.
Okay. Yes. Yeah, Tanujan, yeah. I'm sorry. The time expired and we got pushed into the main room. Basically, we assess pain exactly because of that reason that you mentioned. Different people perceive pain differently. So we ask the intensity of a person's pain from his own mouth, and he should be able to quantify his intensity. The person having the pain is the best person to quantify the intensity of the pain. So that is why we ask that person. We don't assume the severity of the pain and then treat. We just ask them to quantify the severity of the pain and treat accordingly. That is the importance of asking that person, because different people perceive pain differently.
Okay, thank you.
Any other questions? So if there are no questions, we can just wind up the session. Once again, I'd like to thank both Dr. Gayatri Palat and Terry Mais, and also Swaroop being as a facilitator for Terry's session and giving your valuable time and making our session complete. And I would like to announce our topic for our next session, which is going to be on 15th May, which is Saturday. And the timing will be 7:30 to 9:30 p.m. And we are going to continue our communication classes on introduction to breaking bad news and using spikes model and pollution. So it's going to be on 15th May. It's a Saturday, 7:30 to 9:30 p.m. So we are going to see you.
Any feedback?
Yeah, just a second. I'm going to share the feedback link with you. Please give your valuable feedback.
Please give the feedback to make it complete.
Yes, one second.
So we click on the link when you give.
Yes, ma'am. You have to click on the link as soon as I'm just copying it. One second.
Yeah.
Hello.
So once you have given your feedback, you can leave the session, and see you on next Saturday, 7:30 p.m. Can just someone tell me, like, who is the participant with Galaxy A10s? Because I
Dr.
need
Jude.
this. Sorry, sir.
Dr. Jude.
So can you just type your name in the chat, because I need this for my attendance.
Okay. Difficult to. Difficult to write a name.
Thank you so much, Cherry. Once again, we request you to just share 5 learning points from your side, which we can share it with our team. And thank you so much for agreeing to share the PDF version of your PowerPoint with the trainees participants. Thank you so much. Maybe, you can leave. Maybe the participants will submit their feedback. If you have some other work. Thank you so much.
Thank you, ma'am. Bye.
Bye. Thank you so much to Shweta and Pratik for being us and supporting us. A huge backup. Thanks a lot to both of you.
You're welcome, ma'am.
Swati, you can also leave the session, no problem. So if Damayantan, Dr. Jude, and Kamalabeni have submitted their feedback, you can leave the meeting. So we are going to end the session now. So hope you have submitted your feedback.
I did not receive the feedback format.
It's in the chat box. So feedback link is given in the chat box.